Please join me in welcoming Jim Sullivan, a dedicated advocate and educator with the Alzheimer's Association and a nationally recognized community leader. With over 20 years of financial advisor specializing in chronic and terminal illness, Jim has authored more than 100 articles for the AICPA and is the author of Retirement Healthcare Planning Guide and Health Transitions Guide. He currently serves as president of the nonprofit Paying for Alzheimer's, helping families navigate the financial challenges of Alzheimer's through coaching and education. So, with that, Jim, I'm going to hand it over to you. I'm going to kind of go dark, but we ask that people use the chat feature to ask any questions, and we'll take some time at the end to answer those questions. Um, and you don't have to worry about anything, Jim. As they come in, I'll kind of decide whether or not I want to interrupt you. And if I do, then we can go from there. So,
Okay,
um,
now do we have until 11:30?
I think it's 11.
Okay.
Yeah, 11. Yeah. All right. I'm handing it over to you.
Okay, thank you, Ashley. Good morning, everybody. Just by way of introduction, I am a CPA. For many years, I ran a financial counseling practice that focused on individuals diagnosed with either a chronic or terminal illness um, and their families. So I worked with families with everything from Alzheimer's disease to ALS to Parkinson's disease, uh, cancer. And the focus of my practice was not to displace another financial planner. Mine was to add an expertise in working with families where a chronic illness or terminal illness really upset their current financial plan and trying to work with them to, in effect, I would tell them, your financial plan is broken. We need to rebuild it around the fact that you have this terrible diagnosis that's going to impact all of your previous plans. So let's do the best we can with this new reality. Now, I am now with a nonprofit agency I began. Um, my phone number is up on the top, the 800 number, extension 2800. So if you have any questions, we do not sell insurance products. We're purely an educational and counseling um, agency. Our goal is to work with people of all income levels. We don't turn people away if they can't afford our fees. We arrange scholarships for them. So let's begin. Let me give you a little more personal background. I had in 2020, I lost one of my older sisters to a vascular dementia. It was called Binswanger's. I had never heard of it. Kathy lived up in the Green Bay, Wisconsin area. I come from Green Bay, and that's where she raised her family. And I used to tease her that Binswanger sounds more like a Wisconsin bratwurst than it does a vascular dementia. And with as with all dementias, um, towards the end of life, they all look very similar. So with Binswanger's, Kathy was losing her, she lost her higher functions first, and then her lower functions like swallowing near the end. And at a lunch, her nurse left her and she choked on a sandwich and lost additional um, oxygen to her brain. And after a couple days on life support, her doctor suggested to my brother in law and her three kids that they pull the life support, which they did because by then the brain damage was too extensive. So the other problem I think there, or what I learned, because her vascular dementia was pretty rare, living an hour and a half west of Green Bay, there weren't always a lot of doctors in the area that knew about these vascular dementias. So she actually had to go into Green Bay to find a doctor who knew much about Binswanger's. Um, and that's one of the things I tell people as they retire. when you move to another area of the country, in the Chicago area, we're lucky because we have, I think, 9 teaching hospitals in the Chicago area. Everything from Alexian Brothers to Chicago Northwestern Medicine, Loyola, and so you have a wealth of expertise for almost any type of dementia. And that's not always true when you move to areas like Tennessee or Kentucky. You end up having to drive either to Atlanta or Nashville to find the medical care you need. Then in 2022, my older brother died of Alzheimer's disease. He was initially diagnosed, I think, in maybe 2018, 2019. And he lived in Kansas City. He had a PhD in economics and worked for the Federal Reserve in Kansas City. And in Kansas, as soon as he was diagnosed, the state required him to take a driver's test, and they flunked him. They decided his reaction time was not adequate to continue driving. So the state takes that requirement and makes it a law. So in some states, the family has to decide when Alzheimer's is interfering with driving. I'm going through that right now with a brother-in-law who lives in Naperville. He has Alzheimer's, and I think we're going to have to um, take away his driver's license soon. And we'll talk a little more about that in a little bit. So my brother died in October of 2022. Um, it occurred a little quicker than most um, individuals, but nowadays we know that the clinical signs of Alzheimer's actually show up very late in the process. If you look at that box I have over to the left on the first page, it says, and this is from an ARP bulletin, unpaid bills, lower credit scores, and shrinking net worth. Years before people are diagnosed with dementia or other cognitive impairment, they often have difficulty managing money and start suffering financially. And I found that true with my older brother. He was always, as you can imagine, with a PhD in economics, very good with mathematics, statistics, and when he started showing cognitive issues, doing what was to him second nature, we knew there was something wrong. And ultimately, he was diagnosed with Alzheimer's disease. And I think from diagnosis to death was maybe about 3 years. So, one of the things I always emphasize during these webinars is paying close attention to your grandparents, your parents, your siblings. If you start noticing issues that you think might be indicative of Alzheimer's disease, you need to move quickly. A lot of families delay and don't really want to admit there might be a problem. And the problem with that, or the issues that come with that, is that often if you kind of put off finally talking to the other family members about what's wrong with mom or dad, by the time you do that, they may have run into or created a lot of financial problems that otherwise could have been avoided. When I give seminars and webinars on this topic, I almost inevitably have people walking up and saying, my mom or dad were typically very conservative with their finances. They saved money, they didn't spend it foolishly. And then I realized suddenly they had credit card balances where they used to not use credit cards at all or were quick to pay them off. But the in the course of the cognitive disease, your ability to plan becomes worse, and you suddenly begin doing things with your finances that aren't typical. And by the time families get involved, they might discover their parent has a 50 or $60,000 credit card bill that in the past would not have been um, would have been very, very um, strange for them given their financial planning capabilities. So to me, there's no such thing as long-term care planning. It's only a care planning continuum. And I have two clients now. Now, neither of them have um, Alzheimer's disease. Novilla lives in Florida, and she was declared disabled and began on Social Security and Medicare probably about 4 years ago. Suddenly, in December, for whatever reason, and we still haven't discovered the reason yet, she was taken off her Medicare and lost her Social Security disability income. Novilla is not yet age 65. And so at the same time, they diagnosed that she had a stage 4 cancer. And so she was referred to me so that I could help her. So we found out and got her reinstated in Medicare, but unfortunately, Medicare did it not in December when she was originally thrown off Medicare, but in February. By February, she had had 2 months, December and November, of extensive cancer treatment and started to get bills from the healthcare, from the doctors and the hospital she attended. So we are in the process of unraveling that. So my point here is a lot of things come up unexpectedly. Long-term or care planning often throws a curveball, like in Novella's case, and we're hoping to get those December and January bills paid. But this comes up and you have to be prepared. We'll talk about that more in a minute. Luda is a client of mine in the Chicago area. She had had a series of 5 strokes several years ago. At the time, she was under age 65. She became disabled and was also receiving SSDI, or Social Security Disability Income. She was in Medicare. When I met her, she has already age 65. And in talking to her, I found out she had uh, emigrated from Lithuania to the United States with her husband. So they were adults when they moved here. Um, with strokes, her second language was English, but the strokes began to diminish her ability to speak English and go back to the Lithuanian language. So I helped her not only make her Medicare decisions, but we also had to find um, somebody who spoke Lithuanian and could help her with questions she had. Medicare does have a fairly good translation services, and we also found a Medicare supplement plan for her where the company provided that type of language support. Last year, Luda discovered she had breast cancer. She had a mastectomy. Her radiation treatment caused her bones to weaken and she broke her hip. So she spent 6 or 7 weeks in bed with physical therapy. And so it became more and more difficult for her to manage her disease. And it all became part of what I call this care planning continuum. It's constantly throwing you curveballs that you have to be prepared for and aware of. But if you know the Medicare system, you can often overcome that with language services, In the area that Luda lives in the suburbs of Chicago, there's a very large Lithuanian population. So finding a Lithuanian speaking nurse was not difficult. But this type of care planning is necessary as something to keep in mind as you move forward. What I call financial, what we all call financial planning, is is kind of a luxury. I'd say you financial plan, you plan for retirement, for your kids' education, for a vacation, to purchase a car, to buy a home. All of this financial planning takes place, and you're able to look forward, figure out what your earnings are, what your budget is, and begin to plan for these type of goals. With a cognitive diagnosis with Alzheimer's disease, suddenly you're not talking about financial planning, you're talking about financial problem solving. When I meet with families initially, and let me give you the story of Tessa. She, Tess, lived down in Champaign, Illinois. She owned a home. She was unmarried. She worked at the University of Illinois in Champaign. Her mom lived in the southwest suburbs of Chicago. Her dad had died. She was the only child. So when it became dangerous for her mom to continue living at home on her own, Tess made the decision that she was going to move up to the southwest suburbs. She sold her home in Urbana, moved up, and when I met her, we had to sit down and think through. I told her what she was doing, in effect, was parachuting into the middle of her mom's cognitive issues. She didn't know much about her mom's financial situation. So she was really parachuting in and had to get oriented to her mom's finances. So, one of the things I tell people first is often with this type of planning, we are left to choose the best option from a list of poor choices. Remember, I talked about financial planning as something you do prospectively. You have a goal, retirement, your kids' education. So you begin figuring out what your goal is in terms of savings. You start to save. Here, Tess was dropping into the middle of her mom's life, in effect, and had to learn what her mom had in terms of assets and income. So what I did with Tess is, first of all, we put together a um, a list of her mom's assets. And we asked her mom to sit with us and, to the best she could, talk to us about, did she own her home, which she did. There was no mortgage. She owned a car, although her license was going to be taken away from her. It was difficult to live at home alone. Very is actually unsafe. So that's what led to the decision to have Tess move up here and actually live with her mom. Now, the issue Tess had to contend with was they couldn't really afford to live with Tess without Tess working. So the next thing I did is put Tess in touch with Catholic Charities. In Illinois, there is a program where the state of Illinois will pay a family member to care for a loved one who is not able to live on their own. And Catholic Charities is the charity that provides the assistance to individuals who want to join that program. You get trained. I think the pay is $22 an hour, although some of that is paid to Catholic Charities to cover their costs. But this allowed Tess to move in. So there's a benefit not only to Tess and her mom, but the state of Illinois. It's actually cheaper to have Tess to pay Tess to stay at home with her mom rather than moving her mom into a nursing home. And that resolves another issue with families where a family member says, please don't move me into a nursing home. And I hear that frequently. Most people dread the thought of leaving their home and moving to a nursing home. This actually kept Tess in the home to take care of her mom and probably for the foreseeable future. So it was a great resolution and a win for both the family and the state of Illinois. So when Tess and I sat down, we looked at her mom's assets. Her mom got Social Security and a small pension from her husband's former employer. As I mentioned, she owned the home they lived in, so it looked like they'd be able to afford to stay there once Tess got the job as her caregiver paid by the state of Illinois. We do a budget. In other words, we're going to start with Tess's mom's budget, absent the diagnosis of Alzheimer's disease. We're going to look at what it takes to support her mom in her home. Then we're going to add to that estimates for the care costs. So it's what I call a care budget. And it's typically going to go out for 12 to 18 months. We're going to look carefully at not only her current income and expenses, we're going to add Tess's income to that and the cost of having her in the house. And we're going to look at a 12 or 18-month period of time. Now, it becomes difficult to do this type of budget once you've been diagnosed with something like Alzheimer's disease. So I'll typically, along with a family member, talk to the nurse, talk a little bit to the doctor about what he or she sees as upcoming costs, and I'll encourage family members to become part of a support group. And the Alzheimer's Association has support groups all around the city of Chicago and the suburbs so that you can go. And I've always found it very touching how helpful other family members can be to family members who are just starting this journey with their loved ones. In fact, I will often talk to people who are still members of a support group, even though their loved one may have died 2 or 3 years earlier of Alzheimer's disease. And many of them will tell me they really feel that so many people were helpful to them in the support group when they were first going through this, that they feel like they should pay it back by staying in the support group and helping families who are now going through it themselves, and talk to them about what the financial impact is, help them understand the budgeting. And that's why I'm a big supporter of support groups. At the top of the takeaway sheet is the number for Alzheimer's disease, the 800 number, and the phones are staffed by social workers who can be very helpful to families and point you in the right direction for support. One thing I really am excited by as we move down our list is you'll see it highlight, or actually in all caps, the GUIDE program. GUIDE stands for the Guide to the Improved Dementia Experience. It is a test program run by Medicare. And in the Chicago area, as an example, Alzheimer's Association has joined together with a company called Ripple Care, and I give you the email address. They are a telehealth organization on the West Coast, but they are available 24/7 to talk to and actually run this program, or were selected along with Alzheimer's Association to run the program. So, what does the program do? It provides families support who are still uh, living at home, their loved one with the Alzheimer's disease or other dementia is still living at home. So, what I'm excited about it is that it provides the needed support family members who are caregivers need to care for their loved one at home. One of the things it provides is up to $2,500 a year in respite care. Respite care, as many of you probably know, is where somebody comes into your home, a nurse who will take care of your family member while you either take a break from caregiving, which is a high stress job, or go shopping or do something just to get away for a few hours and be able to relax and kind of live your normal life. So that's $2,500 a year. Now, here are some of the limitations. First of all, you have to be in standard Medicare. What that does that mean? You have to be in traditional Medicare, which is parts A, which is hospitalization, part B, doctor's care, and part D is prescription drug. You cannot be in a Medicare Advantage plan. I wish that weren't true, but it is. But when you call Ripple Care, they will explain the program, and there are several others uh, guide programs that are being started on July 1st in the Chicago area. I'm currently going through and starting a list now. If at any time you're interested, just give me a call to that 800 number, 800-820-9232 extension 2800, and I can share with you what I know about the programs that are already in place in the Chicago area or coming online on July 1st. Now, I did a work with a client of mine. Her goal, she lives over in Warrenville. Her husband, Gene, has Alzheimer's, and she wanted to join Guide. And hopefully that 2,500 would be used to pay for his care at an adult daycare facility that's right near her over in this case, in Wheaton. Um, but unfortunately, most of these programs, they'll pay for respite care, but only if it involves them sending a nurse to your house to care for your family member. They won't pay for you sending your family member to an adult daycare. And that can be in the local one, that can be $80 for the morning and 140 or 130 or $40 for the full day. So I'm hoping some of these new guide programs will do that. So if you're interested, feel free to give me a call. I'm going through trying to learn about these new companies now. Some are run by Rush Healthcare, by the University of Chicago Healthcare, this one by Alzheimer's Association. So feel free to give me a call to find out some other names. And we can also discuss what the programs have. And this is something we provide at no charge to people calling in. So feel free. But I think, I think I'm very optimistic that this program will grow in the years ahead and make it easier for you to keep your family member at home. Now let's talk about assets. When I met with Tess, we looked at what assets does her mom have. No retirement savings. Also, she was getting a uh, pension based on her husband's work at his former employer. So she owned her home. That raised the question about using home equity or maybe a reverse mortgage um, to help pay for her care. But I discouraged Tess from doing that. Um, um, Reverse mortgages can be expensive, and home equity. I doubt that somebody who owns a home that's retired, unable to work, would actually qualify for a home equity loan. So my preference was to see what we could do with Tess working as a caregiver, her mom's pension and her social security being paid monthly. And I think they're going to get along fine, but I'll check in with them periodically and we'll talk about their income and how they're doing in terms of their expenses. And as I talked about with Novilla and Luda, you never know when um, something's going to pop up that's going to be expensive. Now, one of the things I talk about um, quite a bit, I'll just mention this briefly, there are life insurance policies that will pay an advanced death benefit. Now, Tessa's mom did not have a life insurance policy. Frankly, she didn't need one. She had no financial dependence since Tess was living on her own as an adult. But there are life insurance policies that pay advanced death benefits. So even before you die, if you're diagnosed with a uh, terminal illness, they'll pay the policy benefit, or some will pay half, might pay three quarters as a source of um, assets to pay for care. Let me give you a story about Brian. Brian was diagnosed with ALS, Lou Gehrig's disease, and this was back in 2019. I was working I would drive up to Minneapolis. Brian and his family lived in Minneapolis. And in the discussion we had about assets, Brian was an employee of IBM. I found that he had a life insurance policy that he paid for on his own. It was worth a $500,000 death benefit. And it would pay if he was diagnosed with a terminal illness and the doctors expected him to pass away within 2 years, it would pay half the policy benefit. Now, in Brian's case with ALS, it is a terminal illness. Doctors did not expect him to live longer than 2 years. Then the question became, did it make sense for his wife to pull the trigger on the policy and get half the $500,000 to help pay for Brian's care? Now, she never did that, and let me explain why. To me, the value of this policy is to give the family comfort that if things um, go bad in terms of care expenses and they're running out of money, this is a nice, um, a beneficial policy to have and to know it's available if needed. One of the things Brian's wife asked me, she said, I would like to quit my job in Brian's last few months of life and take care of him. Can I afford to do that? My response was, my job is to help a family with the decisions they want to make. So when their family member dies, they have no regrets about the decisions they made. So I told his wife, I said, go ahead and quit your job. If we need the money, we can pull it from the life insurance policy. Hopefully, we won't. And you can stay home the last few months of Brian's life and take care of him, which she did. And she's always said after that, She was very happy that she made the decision, even if it would have cost some of the benefit she would have been paid on Brian's death. It was very important to her to be with Brian the last few months of his life. So to me, that was um, a resource available that hopefully you don't have to take advantage of. Remember, up above, I said often we are left to choose the best option from a poor list of choices. Of course, in Brian's mind, that income, that death benefit, was not meant to care for him. It was meant to help pay for his wife, and they had 7 kids, 3 of whom were still at home, and he wanted it to be used for that. But here's a case when I sat down to talk with Brian. This is a best option from a poor list of choices. I worked with his wife to talk about their budget, their care budget. If we needed it, we would pull some of that money from the life insurance policy. But I said, we definitely don't want to do that unless we have to. And that's the way it turned out. So that's an instance where you have a best option from a poor list of choices, and they come up frequently. And that's one of the things I do in my discussion with families. Now, what I don't do with families, I am not a social worker. And when there are family conflicts or arguments, I always make sure that they work with the Alzheimer's Association or call somebody up from the their medical policy to see if they'll pay for a social worker to come in and talk through with the family some of these issues. I'm always surprised when I walk into a family situation that a lot of the issues surrounding a terminal diagnosis or a chronic illness are not discussed openly. I've walked in where the family has not discussed that, for example, Alzheimer's is a terminal disease. I asked a client of mine once, this was years ago, what he and his wife talked about when she was diagnosed with early onset Alzheimer's disease. I said, did you talk about it? And he said, not really. We never referred to the disease itself. We always called it your brain injury or your brain sickness. Um, it just was not something we were willing to face until the very end when we really had to face it as she got closer to death. Because with early onset um, Alzheimer's disease near the end and during the course of the illness, you can be lash out very violently at family members. And they had to make the decision not to bring the grandkids around because they didn't want her, the last memories they had of her lashing out at them for some minor issue. So unfortunately, they thought it was best to keep them away from grandma for the last couple of months of her life. Now, the other thing that I talk to that people should be aware of is Medicare, Medicaid, and other healthcare decisions. There is what I call, or what's called, the Medicare trap. And it's an issue that I come across frequently with individuals who have been diagnosed with Alzheimer's disease, they or other chronic illnesses. A more recent and personal um, example is on Monday. My sister-in-law Susan passed away from ovarian cancer. Um, Susan fought it for 5 years. In December of 2000 or November of 2020, Susan and I met regarding her Medicare coverage because in December she would be age 65. She knew something was wrong. Susan was a nurse, but she didn't know what. The doctors hadn't diagnosed anything yet. She worked at the time, Good Sam, near in the western suburbs, and the doctors weren't sure what she had. So I suggested she sign up for Medicare Supplement, not Medicare Advantage. Why? Because once she was diagnosed with um, ovarian cancer, at the time we didn't know that, but I said, if you're diagnosed with a cancer or any other disease, it's unlikely you're going to be able to enroll in a Medicare supplement plan, particularly an affordable one. So she enrolled in a Medicare supplement plan, and that's what she's been in for the last 5 years. Medicare Advantage plans are very attractive for agents to sell because they pay a higher commission. Medicare supplement plans pay a lower commission. But if you're going to be terminally ill, as it turned out Susan was, you want the Medicare supplement plan in place to pay for the expenses you're going to incur. She could always have switched to a Medicare Advantage plan because there, during the annual enrollment period, you can enroll without answering healthcare questions. So the Medicare Advantage trap would have meant she had to stay in a Medicare Advantage plan and couldn't go into a Medicare supplement plan, which I believe for somebody with ovarian cancer she was better off in that. Last fall, she told me she was very glad that was what she enrolled in because all of her expenses were paid. There was no deductible or co-payments, and she was at Edward Hospital in Naperville, where she lives. She was down at the University of Chicago for some treatment at Northwestern Hospital and had tremendous, as you can imagine, tremendous medical bills, none of which she had to worry about. So I always tell people Medicare Advantage plans certainly have their benefits. But for me, when you sign up for Medicare at age 65, you're typically in good health. In Susan's case, she was not, but we didn't know what the diagnosis was yet. So the real proof of the benefits of a Medicare Advantage plan are what I call the stress test. When you become chronically or terminally ill, how are you covered under that Medicare Advantage plan? And that's what we do, or I do with new clients. I compare a Medicare supplement plan and how that would cover a diagnosis of, say, ovarian cancer or Alzheimer's disease versus a Medicare Advantage plan and how that would cover. That's the stress test I talk about. And that's why, to me, the decision of Medicare supplement plan in traditional Medicare or Medicare Advantage is very important to think about carefully when you first enroll in Medicare. Now, let me comment on another issue I see with clients is they're in Medicare, but they have low income or they have very little assets. There is through the Administration for Community Living, or the ACL, a program called the Medicare Improvement for Patients and Providers Act, or MIPA. If you do a search of the National Council on Aging, NCOA, they have a brochure. I'll hold up. I don't know if you'll be able to see it. Um, Called the Helping Medicare Beneficiaries Save Money. Why do I raise this? Because I think there's probably about 40% of people who are on Medicare don't realize there are these low income subsidies that are available for them to enroll in. They miss them entirely. And the MIPA plan, the Medicare Improvement for Patients and Providers Act, helps teach you what's out there. in terms of dual eligibility, the first thing on my list for Medicare and Medicaid. If your income's low enough, you join Medicare when you're age 65, and then you also pay for Medicaid. And what's the advantage of Medicaid? Medicare has a lot of expenses that you're expected to pay out of pocket. If you qualify for Medicaid as a dual eligible, Medicaid will pay those expenses. Normally, you might buy, say, a Medicare supplement plan for $150, $200 a month, and the Medicare supplement plan would pay for these out-of-pocket expenses. But as a dual eligible, Medicaid will pick those up. And that in Tessa's case, we were able to drop her Medicare supplement, her mother's Medicare supplement coverage, and go on to Medicaid. That saved her, I think, close to $200 a month, which on her income is a lot of money. Well, frankly, it's a lot of money for anybody's income. So you have low income subsidy, the LIS, for your Medicare prescription drug coverage. A lot of people miss that. It's much easier to enroll in now. So think about that. You can even do it now if you have a lot of expensive drugs and get the financial support of the LIS program, the Medicare Savings Program, the MSP also offers various types of financial support, home care, and I'm going to tell you a court decision, JIMO decision, JIMMO, that actually is a program that can provide at home non-medical care for a home health care. If you meet the criteria, which we don't have time to go through now, but a home health aide can come in for up to 35 hours a week to help with bathing, dressing, toileting, transferring. It's not true that you can get this type of non-medical care through Medicare. You can actually get it, and Medicare has been instructed through the JIMO decision to explain to people what this benefit is. So you have to meet the criteria, but the help is there. So understanding federal, state, local, and government sources of support. MIPA, we already talked about. The ACL, the Administrative for Community Living site that I have down there is very helpful. You can put in your zip code and find local programs of support, everything from respite care to other forms of financial support. For taking care of a loved one at home. The National Council on Aging, NCOA, has what's called a benefits checkup. This is a great tool. If you do a Google search for NCOA benefits checkup, they will take you to the site. You enter your zip code, you enter some personal information on your income and assets, and it will tell you what programs are available to you of financial aid in your zip code. It's a great tool. Unfortunately, not enough people know about it, but again, it's a benefitscheckup.org run by the National Council on Aging. So that's another great tool to use for financial support. Now let's move with the time left. We have talk about some typical financial issues. And here, as I said, remember I used that parachuting into the middle of a family when a diagnosis is made, and you have to look at what is. It's too late to apply for long-term care plans. It's just you have to deal with the problems you encounter. So, for example, credit card debt is something I frequently see because family members weren't aware that mom or dad had run up tremendous credit card debt. Well, when you're an elderly person and your sources of income are a pension and Social Security, and you can be what's called judgment proof. In other words, the credit card company cannot attach your Social Security or your pension to help pay back the debt. So, what our group does is work with the elderly who have a lot of credit card debt and try to either get rid of that or reduce it because of their financial circumstances. I know some elderly people don't like to do that. It's not the way they were raised to walk away from debt, but sometimes that's the only way to do it. And it happens very frequently. Medical care debt. I had a client who, when I was introduced to him, had gone through a cancer diagnosis. His care was over. They said he was cured of cancer, but he still had tremendous bills from the care he received when he had cancer. Then he was diagnosed with Lou Gehrig's disease. So you can imagine, what do you do in that circumstances? It's that circumstance. Well, in this case, we had to declare bankruptcy. I referred him to a good bankruptcy attorney. They had to give up their home. It was underwater anyway. The value was below what the outstanding mortgage was. But in this case, things worked out for the family. Um, the patient's wife was a very popular teacher, pre kindergarten teacher in the north suburbs, and her brother in law put out a GoFundMe page and told everybody about the plight and that they need to raise money for his care. And I think within 2 weeks they had raised $80 or $90,000. So GoFundMe page has been helpful in a number of circumstances and is something to think about um, if you run into these problems. I had a client who had ALS out in North Aurora. She was really confined because of her physical problems to the first floor. It was a house that was built without a bathroom on the first floor. They did a GoFundMe page and they were able to raise $30,000 to put in a bathroom on the first floor that accommodated her um, wheelchair. So it really ended up being working out well for him. Anne died um, probably 4 or 5 years ago now, but she was able to live comfortably. The thing I remember about Anne is at one meeting towards the end of her life, she asked me. She said, "Are you doing okay?" And I said, "Yeah, why?" She said, "I know these meetings with me are tough, so I just wanted to make sure we weren't expecting too much out of you." And I've thought since, here was a woman dying of ALS. She had 3 kids, 2 of which still lived at home. She was only in her early 50s, and she was worried about me. And I thought that is why I tell people I get much more out of this practice than um, I ever give. It is astonishing to me how kind people are in the last few years of their lives. But we're, we have 5 minutes left. We'll talk about the benefits of early planning. And I want to draw your attention to one thing that's important for people with Alzheimer's. You've probably read about the new drugs that are available, Lakembe and uh, Kinsula. Um, they are not drugs that cure Alzheimer's, but they slow down its progression. They are very expensive. And when they first came out and Medicare approved them, that meant that Medicare would pay for those drugs. And people called me and said, well, I don't see that Part D pays for the drug. Part D is covers prescription drugs. And I said, that's because both drugs are infused, meaning you go to a doctor's office or an infusion center and they hook you up to an IV and it's infused into you rather than a pill you take at home. I do that now at Central DePage. I get an infusion for a different drug every 56 days, where I have to go into the infusion center. I'm there for 3 hours, and it's paid through Medicare Part B, not Part D. Now, let me give you one quick warning. If you are on Medicare supplement plan, Medicare will pay 80% of the cost, and depending on the plan you're in, the Medicare supplement plan you're in, it will pay the other 20%. If you're in a Medicare Advantage plan, it may not pay that other 20%. And as you can see from my numbers, it's an expensive drug. But as always, if you're thinking about these drugs, discuss the side effects with the doctor, obviously. And the more than normal aging.lilly.com, I think is an excellent site. They developed one of the drugs, and it's an excellent site to go to learn more. Let me conclude with an important issue, I think, in all families. In all families, there's a money tension. When I walk in and meet the family the first time, the well members of the family will tell me, we don't care what it costs. We want to take care of our dad, our mom, our grandparent, or sibling as best we can with whatever money we have. The patient, on the other hand, will say, I don't want to bankrupt my family because of my illness. That is a discussion that um, often they don't have till I walk in and raise issues regarding budgeting and the cost of the disease and how they'll get it paid for. I always recommend in those cases to involve a social worker if it's an intractable problem, because that's something that as a CPA, I'm not qualified to help a family with. That's really better in the hands of a social worker. And I respect their ability and talents in dealing with these tough issues. Um, so, but that's it. The only other issue is think about when you're thinking about the care plan, what do you do with the when the caregiver becomes ill? Let me go back to my discussion. My sister-in-law Susan, who passed away on Monday, her husband Gary has Alzheimer's disease, and he's continually getting worse. He can no longer live at home. And near the end of Susan's life, she was too sick to take care of him. So she was the caregiver for Gary. But as her Alzheimer's disease progressed, she didn't have the energy uh, to follow Gary around the house, as she said, to remind him to turn off the stove. So you have to think about, if the primary caregiver gets ill, what do we do? And that now I'm at the end of my presentation. You have my 800 number. Call me if you have any other questions. And I hope this was helpful for you. And I can take questions now, but I'm not sure we have time. It's 11 o'clock.
Thanks, Jim. There's just a lot of comments in the chat about people sending their condolences to you about your sister passing, and that we're thankful that you're able to give your time to us today to talk about, like you said, the worst, you got to make a choice on a list of bad choices. So I did want to just remind everybody that I sent out an email yesterday that has Jim's document on it. So you take a look at that. If you didn't write down his phone number, you have the document in your email. It came from me at ajohnson@vapld.info. But I will share it again when I share the reporting. There is just a couple questions if you have time.
Sure.
Um, are there programs, I think you kind of answered this, but are there programs that provide respite and or grants for family caregivers that aren't specific to Alzheimer's care?
Yeah, and I should clarify that the guide program actually applies to all sorts of dementia. So somebody with Parkinson's disease can have a dementia or Lewy body's dementia. So if your family member is diagnosed with any type of dementia, they can get respite care through guide if they otherwise qualify. The other thing I would suggest is the Administration for Community Living, ACL. If you go there and put in your zip code, often they will have either private foundations or government programs that'll pay for respite care. In DuPage County, there is one that'll pay up to $1,000 for respite care, and it doesn't matter, I think, what the disease is. It's just that the person needs the care and a caregiver.
There was another question. Somebody's kind of asking what if you could share a little bit about your fee structure for the services that you provide.
Yeah, as I said, we um, have a fee structure. It's modest, and our goal is also we never turn someone away because they can't pay our fee. We have a questionnaire you fill out, and then we determine what you can afford. And if what you can afford is zero, we still provide services. In setting this up, that was my goal. It seemed to
Mhm.
me families have enough problems when they get this diagnosis without having to worry about how do I get guidance on providing care and what programs are out there.
I just recently had another library program on Medicare and Medicare options, and it's so complicated, let alone adding in, like you said, a disease, an incurable disease. So, very happy to hear you share that. Is there a way out of Medicare Advantage plan, and what are the problems with switching?
That's a very good question. Between October 15th and December 7th, if you're in a Medicare Advantage, you can actually unenroll, in this case for 2026. The disadvantage is that now you can enroll in another Medicare Advantage plan, but also if you want to enroll in a Medicare supplement plan, you may have difficulty because the Medicare supplement plans that are out there will ask health questions. And if you tell them you're diagnosed with Alzheimer's or Parkinson's or any other disease, they're not going to issue you a policy. Now, we're
Mm.
in Illinois, so there's a special exception. Blue Cross Blue Shield has what's called a standard plan that you can enroll in that they don't ask health questions. So if I have somebody, and I have had people that have just been diagnosed with um, a cancer, they can enroll in the Blue Cross Blue Shield. It's a little more expensive than the other plans because it enrolls everybody, but it's a great alternative. And if you have any questions, just feel free to give me a call. But it's a lifesaver. The other thing you have now, you have, I think, in about 12 states, you have a birthday rule. So in Illinois, the way it works, if you're near your birthday, I think between age 65 and 75, you can change your coverage in Medicare supplement plans. So there are ways to get out of a Medicare Advantage plan, but they differ by states. In Illinois, we have that special, we have Blue Cross Blue Shield, and hopefully they'll continue offering that. But I have clients in almost in a dozen states. So you have to be familiar with what those rules are to try to get you out of Medicare Advantage.
Mm.
And some states
All
like
right.
Connecticut and New York have year-round open enrollment. I think
Mm.
California does too, but you're from Illinois, so it doesn't help. But call me if you have any questions.
All right, Jim. Thank you for your program today. And like I said to everybody, check your email if you didn't write down his contact already and reach out to Jim. Very helpful, kind human. So we appreciate you and thank you for your time today. Okay.
So you're welcome. And just the last quick, my sister-in-law Susan would have been mad had I not showed up. She was a nurse, so she knew service.
Okay. Very good.
Thank you,
Thank you,
everybody.
Jim. All right. Have a great day.
You too.
Bye bye.
Bye.